If you are pregnant or you've recently had a baby, this podcast is for you. I'm your host, Kath Bequee. I'm a physiotherapist working in women's health and mum of 3. Inside my online program, Fitness Mama, I help women feel confident and strong inside out as they navigate pregnancy, birth, and postnatal recovery. Each week, I bring you 2 episodes to support you on your motherhood journey, whether it's real and raw birth stories from fellow mums, expert interviews with trusted health professionals, or bite-sized Q&As where I answer your most common questions. It is possible to feel amazing in your body during this stage of life, and I want that for you. Come and say hi on Instagram at kathbequee.physio, and let's dive into today's episode. Hello, welcome back to the Pregnancy, Birth and Recovery podcast. Today, I chat to obstetrician gynaecologist Dr Shavi Fernando, and we discuss the topic of induction of birth. It's a fabulous episode. If you're pregnant, if you've been told that you might need an induction, or if you're curious about it, in this episode today, Shavi discusses what exactly is an induction of birth, why might it be considered, why might it be recommended, what are the most common reasons women are offered an induction. We then go into the common myths and concerns that women have. For example, we talk about the potential cascade of interventions that's often talked about. We talk about any risks that might be associated with induction. We go on a tangent all about pain relief and analgesia, and Dr. Shavi shares heaps of information about epidurals. And then we discuss the methods of induction. So, really fabulous episode. It's one that I wish I had listened to before my first bubs, which was an induction. And I trust you're going to get a lot of value out of this episode today. Dr. Shavi Fernando is a specialist obstetrician. He's been one for over 10 years. He's trained at Monash Women's Hospital and completed his PhD at Monash University. He's got a public appointment at Monash Women's, the largest provider of maternity services in Victoria, and he also practices privately at Cabrini, Jessie McPherson and Waverley Private Hospitals. In addition to this, he is also director of the undergraduate curriculum and assessment for obstetrics and gynaecology at Monash University, and Dr. Shavi balances this all with his kids, a daughter aged 9 and a son aged 6. So, without further ado, let's get straight into this episode where we talk about induction of labour, including common myths and truths. Shavi, thank you so much for joining me on the Pregnancy, Birth and Recovery podcast, discussing all things induction of birth.
Thank you for having me, Catherine.
As we were discussing off air, had a episode on this back in 2021, so it's so great to be able to do an update because it's a very common, I guess, a question and concern. Is that what you find amongst pregnant women?
I find that a lot of women are quite afraid of induction. I can understand why, but at the same time, I don't think they really need to be. Also, induction should be reserved for indications, for reasons, but also it's not as bad as I think everyone seems to think.
Okay, well, let's get into that then, because can we all get on the same page in terms of our understanding about what exactly is an induction and why might it be recommended?
So induction of labour means that essentially when you're not in labour, the doctor or the midwife will put you into labour, will make your labour start, basically from 0 to labour. When you labour spontaneously, that will happen naturally, so you'll go into labour by yourself. But if you don't labour spontaneously, one of the ways to try to prevent a cesarean is to induce your labour.
Okay, so is there a certain week gestation that you'd start to think, okay, it's time? Or certain indications, I should ask?
Yeah, there's both. So for weeks gestation, if everything's going well in an uncomplicated pregnancy, in general, you can be induced anytime after 39 weeks quite safely for both you and for the baby. If you're talking about indications, in general, probably there's a lot of indications, but the best way to summarize the indications would be when the baby is safer out than in. That's the right indication. There are lots of different parameters that we look at when we're trying to decide whether the baby's safer out than in. But that essentially is what we're doing. Now, that may be for fetal reasons, that may be because of baby reasons, or it may be because of maternal reasons as well. So if the mum has some medical issues that might impact her health or the baby's health, that also might be a reason to be induced, not just if the baby's not well.
Do you mind going into a few of these, or are there too many to mention?
No, I can go into a few. I can go into a few of the common ones, or at least the
Yeah.
commonly cited
Yeah, the
ones.
common ones. Hmm.
So the common ones would be if you go overdue, so post dates, we call it post dates pregnancy. And the reason for this is because the stillbirth risk post dates is much higher. And stillbirth, as you would understand, is probably, well, it's the second worst complication in pregnancy. And a term stillbirth is horrible, and a post-date stillbirth is just a waste. And so going overdue would be probably the commonest reason to be induced. Yeah.
Oh, what do you classify as overdue? That big
So
question.
the internationally recognized maximum gestation, if you like, for safety is 42 weeks. In general, past 41 weeks, a lot of people will, like a lot of private obstetricians and even public clinicians, will recommend induction by 41 weeks. Technically, overdue is over 40 weeks. So once you're over your due date, you're overdue. But post-date's induction can wait as long as 41 or 42 weeks.
Okay. And do you have any percentages? Like, what are we actually talking about when you mention increased risk of this
Stillbirth?
stillbirth? Yeah. Like, do you have any percentages like before 40 weeks versus after?
Yeah, if we look at the whole population, so not just high-risk women, but everyone included in that population, the risk of stillbirth at 37 weeks is about 1 in 3,000, which is small. Like the risk of 1 in 3,000 is quite little. And the
It's
risk
still
of
quite large.
it's higher than you think.
Yeah.
The risk of stillbirth at 40 weeks is about 1 in 1,000. The risk at 41 weeks is 1 in 500, and the risk at 42 weeks is 1 in 250. Now, 1 in 250 is 0.4%, so it's still quite little.
So 9.6% chance that everything will be fine.
Yeah, correct. I think that's really important, actually. 99.6% chance that won't be a stillbirth.
Yeah.
But there are other things to consider also when you go overdue, not just the stillbirth risk. The other thing to think about when you go overdue is that the placenta has an expiry date. And for each woman, that's a different date. We don't know when it is. And as the placenta ages, it becomes less efficient at giving the baby oxygen. So a labor is stressful for a baby, whether it's induced or not. A labor is stressful. That's just the nature of labor. And most babies who are well will cope with that stress. But if their placenta is not functioning as well, they may not cope with that stress as well as if it is functioning well.
And how do you know if the placenta is functioning well or not so well?
And that's the tricky bit. You often don't, and you may not know until you're in labor. So until the baby is stressed, we don't actually know how well the baby's going to cope. There are some things we look out for which give us an indication. So for example, and this comes to another reason why we might induce your labor, is if the baby's very little. So if the baby's small, it suggests that the placenta is not giving the baby enough blood to grow appropriately. And we can measure that on ultrasounds. Ultrasounds do have an error margin in them. And so we factor that in when we're discussing how we're going to act on an ultrasound result. Also, we look at the blood flow to the baby through the placenta or through the umbilical cord. We can check how much blood the baby's getting. And we can also check the fluid level around the baby, which is the baby's pee. So babies that are not getting enough blood, they pee less, so the fluid level drops. And so we can detect that as well. So these are all things that we use to decide or determine whether the baby's well.
Yeah, that was the reason I was induced with my first.
Yeah, it's quite a common reason. And again, it comes down to whether the risk of not inducing you is higher than the risk of inducing you. And basically, as an obstetrician, as midwives, our job is to balance the risk. So to decide when the risk is outweighed by, or when the benefits are outweighed by the risks.
Yeah. And it's usually a few different factors, right? It's never usually
Yeah.
just the one.
It's not, I think a lot of people think it's just one, and that's very simple, but it's not always that simple. And a lot of the time, it's also it's quite, it can change quite quickly. So it's going to be going along really well and normally, and then all of a sudden it isn't anymore. And being able to shift with that is really important too.
Did you know one of the best ways to support your postpartum recovery is through exercising carefully during pregnancy and preparing your body for birth? And this is something we cover inside Fitness Mama. This is what fitness is all about with its physio-created workouts. We help you support your changing body during pregnancy, whether or not that's with pelvic girdle pain-friendly workouts, whether or not that's with strength training for pregnancy or pregnancy yoga. We help you to prepare your body for birth and reduce your risk of 3rd and 4th degree perineal tears and episiotomy. And we help to boost your postpartum recovery, whether or not you've had a vaginal or a cesarean birth. If this is something you want to do, then come and check out our free 7-day trial. You've got nothing to lose, everything to gain. And at the end of the day, it's all about helping us have a better motherhood experience, to help us feel stronger inside out in every aspect of our life: physical, mental health, confidence. Anyway, I could keep on going, but come and check out the link in the show notes and join our free 7-day trial. See you soon. Yeah. And is that why generally, I assume, the closer you get to 40 weeks, the number of checkups, visits
Yeah.
gets greater? Yeah.
So and there's a couple of big things that happen in the third trimester, or big risks that increase in the third trimester. One is stillbirth. The other is preeclampsia or high blood pressure. And both are quite serious issues in the late part of the pregnancy.
Mm-hmm. Didn't mention gestational diabetes. Would that be one of the common reasons why someone might get induced?
Yes. So gestational diabetes, especially when it's poorly controlled, or not, poorly is maybe not the right word, but when you need a lot of treatment or not a lot of help keeping your blood sugar under control, that can be dangerous for the baby. People know quite a lot about how gestational diabetes causes big babies. And I think that's what everybody knows about gestational diabetes. What not everyone knows about is actually the main reason that we as obstetricians care about GDM is because it also increases the risk of stillbirth. And when it's not well controlled, or if patients are requiring a lot of medication to keep it controlled, the risk of stillbirth is higher. And that's why in women who are term with gestational diabetes, particularly severe gestational diabetes, we would recommend induction.
Mm-hmm. And would they be the main reasons within indications for induction? The most
I'd say
common?
they're probably the commonest reasons.
Yeah.
Sometimes there's the maternal request, or social induction is the other term that can sometimes be used to describe that. So this might be because a woman is just wanting to meet the baby earlier. Maybe their family, or they only have support for a limited amount of time.
Yeah.
So these are other reasons why we may induce a labor. Obviously, these have some additional considerations to take into account. Mental health can be another reason, or pelvic instability, or pelvic floor, or pelvic pain can be another reason why we might induce a labor slightly earlier. In these settings, particularly social inductions, we would always try to get the baby as close to the due date as possible.
Yeah. Okay. So you just said pelvic floor, and I was like, let's chat more about that. Pelvic floor physio I am.
Yep.
So you mentioned big babies before, and the risk of stillbirth. How about the big babies and small small pelvises or perhaps big partners and small mums and pelvic floor trauma risk. Where does that come into it at all?
It does a little bit. And this is where again where it gets a little, all of obstetrics is tricky, right?
Yeah, yeah.
And this is, I think, a lot of people don't understand that either. But I think the problem is it's all grey. There's no real black or white. It's very hard to be black or white in a medical field, especially in
Yeah.
something like delivering babies. Um, the bigger the baby gets, the more the risk of pelvic floor damage and trauma. Um, the bigger the baby gets, the higher the risk of intervention in terms of instrumental delivery, episiotomy, and cesarean is higher as well with larger babies. The main issue is that it's difficult to predict the size of a baby when it comes to big babies. So we're better at ultrasound is more accurate at detecting little babies.
Okay.
But the number of times I've heard of women being told that their baby is going to be 4 kilos and they have an elective Caesar and the baby comes out 3.2, it happens not infrequently. And so I would say that doing a Caesar when it's just based on an ultrasound measurement may not be the best, like an elective Caesar, may not be the best way of managing or preventing pelvic floor trauma.
Yeah.
And actually evidence suggests that too. So evidence doesn't suggest that inducing for a bigger baby would necessarily prevent pelvic floor trauma.
Yeah.
But it kind of makes biological sense that a bigger baby will cause more damage.
Yeah. But as you mentioned, it's like one piece of the puzzle. And, once we determine if someone's got a family history of pelvic floor issues and prolapse in the family, or if they've had an internal, pelvic floor assessment with a pelvic floor physio, they might know if they've got overactive, like hypertonic pelvic floor. And so there's lots of other factors that we can look at first.
I think it's very easy to simplify. I try to oversimplify things, and sometimes we have to make it easier to understand.
Yeah.
But it's never as easy as it sounds.
Yeah, absolutely. Okay, can we discuss some of the big myths that, well, maybe they're not myths, so let's chat about it. But the biggest one I hear is if one intervention happens, so let's say a woman needs an induction, is this more likely to lead to the cascade of interventions?
Yep. So the cascade of interventions is what the idea is that when you have one intervention, so you do something to make something happen, you create more interventions. So it leads to more interventions. The short answer is no, it doesn't actually work that way. Traditionally, I can understand again why people think this might be the case. For a long time, the medical profession itself, even not just midwives, but doctors as well, thought that induction increases the risk of Caesar. Now, we've got to think a bit about why women are induced. So we went through this already a little bit, but let's say your baby's little or not getting enough blood, or you have gestational diabetes, or you have high blood pressure, or you're overdue and your placenta's a bit older. If we induce you for those reasons, your baby is already at a stress point and is less likely to be able to cope with the stress. So in those women, if we induce you, probably your risk of Caesar is higher than a woman who doesn't have those risk factors.
Yeah.
However, if you went into spontaneous labor and you had those risk factors, your risk of Caesar is still high.
And this is where just because something's correlated, it doesn't mean it's causative.
Causative. Yeah, exactly. So and this is a really good example, a prime example of that. So a few years ago, there was a big trial called the ARRIVE trial, quite a famous trial. It's a landmark trial in our field, which looked specifically at women who were having their first babies, who were low risk and had no medical reason for induction. So this is really important. So they didn't have diabetes, they didn't have high blood pressure, they didn't have small babies. These women were excluded. Then they randomized these women. This is also important. They randomized these women to either be induced or to see how they go in labor. And actually, they found this study, which was a large trial, found that inducing women who are low risk, first babies, for no medical indication, at 39 weeks reduced the risk of having a Caesar. Now, this is only one big trial that's been done that's found this. It's a well-designed trial. But probably what it means is at least it doesn't increase the risk of Caesar. And that's what I would usually tell my patients too. So if you're worried about Caesar being the outcome that you're wanting to avoid, induction is not the reason that you end up with a Caesar. For a low-risk woman having her first baby, we can try to extrapolate to other populations, but you can't without the evidence.
And correct me if I'm wrong, but that's a similar situation to the research where epidurals, but everyone said epidurals leads to cesarean too. Isn't that right? Where,
No, so epidurals don't lead to Caesar either.
well, that's right, where
Yeah.
everyone thought that because, yeah, you
No,
explain it
same
better.
thing.
You
Yes,
go
I know
for
what
it,
you mean.
Shavi.
Yes. No, you're exactly right. So epidurals, what epidurals do is well, first of all, they're great analgesia. They're really good for pain relief. They're the only thing that is available in labor that can take the pain away. They don't always take the pain away, but they can. Gas, morphine, water injections, all of these tend to either distract from the pain or just take the edge off the pain, but they don't take the pain away. Um, Epidurals can. So they're a really useful tool in women who need them. At the same time, if you don't need them, you don't need to have one either. So I think that's really important too. I sometimes hear from women they're usually in one of two camps. They're either I definitely am going to have an epidural, or I definitely don't want an epidural. But actually, you don't really know until you're in labor whether or not you want one or need one. And I would recommend waiting to see how you go before making that decision. And you can make that decision quite late in your labor as well. But with an epidural, once you have the epidural, what it can do is it can take away the sensation or the natural responses that you get to progression in labor. So I've also heard that epidurals slow down labor. Um, they don't they don't slow down the first stage of labor. The first stage of labor is up to full dilation, so until you get to full dilatation. And at that point, or up to that point, they don't slow it down, but what they can do is they slow down our assessment of the progress of labor. So, for example, if you're 4 centimeters dilated, we'd ordinarily examine you, let's say 4 hours later, to see whether you're progressing or not in labor. If you have an epidural, let's say you have an epidural at 4 centimeters dilated. Half an hour later, you could be fully dilated, but if there's no signs of that and you have no pain, we may not know until 4 hours after that last examination, when we do the routine examination. So in that sense, it can slow down the assessment of the progress of labor. Does that make sense, Kat? You got that?
Yeah, and does that, because I have had an epidural once, but I could still feel when the contractions changed and I needed to push.
Yeah.
So, and I know there's different types of epidurals to Shavi, like the different levels. Does
Yeah.
that take it in anything different
Yeah,
with the?
so in Australia, at least in Victoria, I haven't worked anywhere other than Victoria, but in Victoria, there isn't really different types of epidural as such. It's more your response to the epidural might differ. There are different ways that the epidural can be performed by the anaesthetist, and different medications that they use depending on the case. Um, I think the ideal epidural is an epidural that takes away the painful contraction, so the pain in the abdomen, but leaves the pressure so that you can feel when and where to push. That's the ideal epidural, and some women will get that. And that means that when you get to the pushing stage, like you would have had by the sound of it, you could feel when and where to push. But you don't always get that, and you can't necessarily predict that. And one woman who had it in one labor may not have it in the second labor. So this is important too, or vice versa. You may have had the completely dense epidural the first time, and the second time you actually can feel it. Um, and that makes it tricky to make that decision. So I often will tell women don't use that to decide whether or not to have an epidural. But it can slow down the second stage of labor, which is the pushing stage, because if you can't feel when and where to push, it can make it a bit more difficult. So that can make that second stage of labor longer. So, and if your second stage of labor is longer, you're then more likely to need a forceps or a vacuum. So an epidural does increase the chance that you might need a forceps or vacuum, but not Caesar. So it doesn't increase the risk of Caesar.
Can I ask you a
Of
question?
course. Of course, that's
Which
what I'm
one,
here
which
for.
one do I ask first? I've got a few on my mind. Um, can you comment on the walking epidural?
Yeah. So in Australia, I'm pretty sure in Australia, not just Victoria, there's no such thing as a walking.
Oh, really?
Yeah. I think the reason might be more a safety thing than an actual thing. So I have seen at least one woman, remember this is one out of 15 years, who could be on all fours with an epidural, have good effect of pain relief for her contractions, but could feel the pressure of pushing. But I would never have let her stand up by herself on the side of the bed or on the
Mm,
floor. The issue is if you think you've got control of your legs and you
mm,
don't,
yeah,
it can be a disaster when you're in labor, especially in the pushing stage.
yeah,
Um, if you fall, you
yeah.
break your hip or your leg or your knee or whatever while you're in labor, it would be a disaster. So we don't do them in Australia. I think in America, I've heard of it in America.
Okay.
Um,
I thought there was something that just targeted the pain receptors, not the motor.
I
I don't
think
know.
that's what they try to do.
Okay. That's the goal.
That's the goal. I think that's the goal anyway with
Mm,
the epidural. But as I mentioned earlier, the variation in response to an epidural is so wide that it would not be something that an anaesthetist could promise, I think,
yep. Okay.
safely.
Another question, and I wish I should have pulled up this research, but at the most recent research update,
Yeah.
where we discuss all things pelvic floor and pelvic floor outcomes post-birth, um, there they sifted through some of the recent research with epidurals, and it's very small amount of evidence, and it's like this is like infant in the infant stages, but it was suggestive of the potential that low level epidural, so not the dense blocks, but it may have a protective effect on the pelvic floor, which for me as a physio, that makes sense because when we're in pain, there's a reflexive contraction, a pain response contraction. And if we're not in pain, then we're more likely to relax through the pelvic floor and have an effective push. What are your thoughts on that?
Yeah, so I think that would make sense. Like you said, the evidence is still early, but the other thing I think epidurals often get a bad name for is not just about progress in labor, but also perineal trauma, like tearing.
Mm,
Um, in my experience, women with an epidural can be more controlled at the end stage of the second stage of labor, like when the head's crowning, and they can slow down the pushing more easily with an epidural than without one because
yeah.
the impulse to push is not as strong.
Okay.
And
Yeah.
that allows more time for stretching in the pelvic floor.
Yeah.
Um, I think the theory behind a negative effect of the epidural on the pelvic floor may be related to the longer second stage. So the longer that the head's sitting there in the pelvic floor, putting pressure on
Mm,
the nerves and the blood vessels and the muscles, the more likely there is to have some pelvic floor
yeah.
damage. I think that's where the theory comes from.
And have you seen in your practice that epidural is more likely to lead to forceps and issues with the pelvic
No,
floor?
no, I haven't in my
No.
practice, but
Okay.
I do something maybe a little bit different. I don't know whether everyone does this, and I know that at least in the public system, it's not routine practice. But in women with an epidural, I understand that they don't have the normal biofeedback that they would get if they didn't have an epidural. And so to counter that, what I do is I do something I call guided pushing. So guided pushing is essentially it sounds a little bit invasive. That's the only real problem because essentially what I do is I'll sit there with my fingers in my patient's vagina um, while she's pushing, and I'll tell her when she's pushing well. I'll tell her how to change the pushing direction or the positioning or the length
Mm,
or the strength, and I'll be able to tell her which contractions to push on and which ones not to push on because I can feel which ones are strong based on how well they move the baby's head. And so quite actively, I'm guiding this patient through her pushing stage with the epidural, trying to give her, or at least give some level of feedback to her because she can't feel that herself. And I find that by doing that, two things. One is because I'm already there. If the baby's getting stressed, I can wait longer because I can give her that extra time because I'm already there. So that means if the baby's getting stressed and she needs a forceps or a vacuum, I just can do it because I'm right there. So that means I can wait longer. I can push the baby a little bit harder before I actually have to do that. But also the other good thing about it is that I also get a really good feel for her progress, how well she's pushing, how tired she's getting. And I find that by doing this, my forceps and vacuum rates are much lower because I can get them to a normal birth more easily or within the recommended time frame for pelvic floor protection.
Mm. And is that if, and we're going off topic, I knew we would.
That's right. I like going. I'm always good at going off topic.
Um, so when you're offering someone, or let's say a baby's not progressing, you're noticing it's not an effective push, things aren't going the way you'd hoped, and you're thinking, okay, we either need like might need a forceps here. Do you offer, and is this a conversation you have during pregnancy, whether or not someone would prefer an emergency cesarean over a forceps?
Yeah, so this question does come up. I'm glad you asked this question, Catherine. I really like talking to you actually, because you're asking all the same questions that I get every day with my patients. There, 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 there comes a point in your labor where it's actually safer for both you and the baby to have a forceps or a vacuum than a
Mhm.
Caesar. So there's up to a certain point in your second stage of labor, a Caesar might be safer. Then there's this narrow window, quite a narrow window, where both are equally risky. Both a Caesar and a forceps are equally risky. Then there's a period past that point where a forceps or a vacuum becomes safer than a Caesar. So that's basically the point where the head's almost out of the vagina. So to do a Caesar, you have to put your hand underneath through the abdomen, underneath the pubic bone, almost all the way out of the vagina, and then bring the head up all the way back through the birth canal into the abdomen to be delivered by Caesar. At that point, there are quite high risks for both the mum and the baby at Caesar as well. And so at that point, a forceps or a vacuum may become safer. And that's usually when an obstetrician would recommend that over a Caesar at that
Yeah,
point.
makes sense.
The risks at that point can be scalp damage to the baby, but fractures of the skull, bleeds in the brain, also risks to the mum's uterus in terms of tearing around the angles of the uterus,
Yeah,
which can damage big blood vessels inside that supply the uterus.
yeah. So in that case, forceps is safer.
That case, forceps
Yeah.
would be safer. Yeah.
And you'd obviously, there'd be situations where if you can do a vacuum, you'd choose a vacuum over a forceps.
Yeah.
Yeah.
So this is another one that comes up too. I think vacuums look really much nicer than forceps. Like if you show a patient who doesn't know anything else about birth, if you show her a vacuum and you show her a pair of forceps and you say, which one do you want me to put in your vagina? I know which one they're going to choose. The forceps looks horrible. Like they're just big metal tongs, right?
Yeah.
They look horrible. Interestingly enough, as a general rule, now this is a broad generalization, so I don't want anyone to quote me on this, but interestingly enough, a forceps tends to be safer for the baby and riskier for the
Hmm.
mum. This is counter to what most women think. I think most women think the forceps are more dangerous for the baby just because they look horrible.
Yeah.
Um, and whereas the vacuum tends to be more risky for the baby and safer for the mum in terms of pelvic floor damage.
And how's the vacuum risky for the baby?
The baby. The way that the vacuum works is by creating suction on top of the baby's head. So
Mm.
it holds on by suction. Now, by doing that, what it does is it pulls the baby's scalp tissue into the cup, into the suction cup, to hold on to it. And in doing so, can cause bleeding in small blood vessels in the scalp. So not in the brain, but in the scalp. And these bleeds can extend. So even most of the baby's blood volume can end up in the baby's scalp. And that can be quite dangerous for a baby, particularly in the early days of life and can drop the baby's blood pressure. Sometimes the baby needs quite significant monitoring, sometimes blood transfusions.
What's the percentage? What's the likelihood that that will happen?
Subgaleals are, so we call it a subgaleal hemorrhage, quite low risk. So I'd probably say in the 1% mark,
Okay.
maybe
Okay.
even less than that, if
Yep.
if the vacuum is used appropriately.
Yeah. Okay. So 99% likely
But
that
won't
baby
happen.
will be fine.
Yeah.
Good. Okay. We started talking about the cascade of interventions. To summarize, you mentioned induction doesn't cause that when you take into account the
Reason for induction.
reason for induction. Thank you. We've talked about the risks to waiting and not being induced. From a safety point of view, I guess I've got one more question. How does an induction compare to spontaneous labor when it comes to recovery for both mum and bubs? And I know it's a broad question, but
Yes, it depends on a lot of factors. Recovery, I think recovery is a really it's a really complicated, complex thing to look at because it's not just physical, it's also psychological and mental. There are a
yeah,
lot of external factors that will influence that. So that's
yeah,
the amount of support that a woman has around her birth, etc.
yeah. Well,
Um,
let's talk about physical, like hemorrhaging or
yep.
any extra risks.
So induction probably does increase the risk of bleeding after the birth. So postpartum hemorrhage. Uh, the inductions tend to be faster than spontaneous labors. So if you labor spontaneously, the build-up tends to be slower, and a lot of women say that this is something they want or they prefer
Mm.
over induction, whereas induction often it comes on quick.
Boom.
Um, and part of the reason for that is often the induction is the way that I would describe it to women is that it's like with an induction, you're entering your labor partway through the labor. That's why it starts so quickly.
Yeah,
Whereas with spontaneous labor, the latent phase of labor, as your cervix gets softer and opens a little bit, can take days sometimes.
yeah,
That's not always a good thing either, because that could take days of no sleep. And
yeah,
then you get into labor, and
yeah,
then you're actually in active labor, and then you have to
yeah,
push a baby out. So there are issues with spontaneous labor as well. That doesn't happen with every spontaneous labor, and it's
yeah.
less likely to happen in your second labor compared to your first.
Yeah, right.
Um, but now I've forgotten your question because I went tangential too.
Yeah, no, that's okay. We were talking about in terms of the recovery or any issues with the recovery
Oh,
side or
induction.
complications post-birth. Yeah,
Uh, induction.
not really.
Not really. Like,
Okay.
because so I think induction is still labor, and I think this is something that's really important to remember too, because women talk to me about whether induction is more painful than labor, and usually I'll just say labor is painful, and all we're really doing with an induction is controlling the labor.
Hmm.
So the main difference between a spontaneous labor and an induced labor is that we can control to an extent your labor with an induction.
Yeah.
We can slow it down by turning the oxytocin down. We can increase it, make it stronger by turning it up. We can
Okay.
stop it sometimes by
Yeah.
stop. Yeah.
Well, you've just gone straight into my next question, so perfect segue. What are the main methods for induction? And have you got a preferred method?
Yeah, so there are three ways you can prepare the body for labor. So an induction is usually a two-step process. The first is we call it cervical ripening. I hate the term, but I'm going to call it cervical preparation. So basically getting your cervix ready for labor, but getting your cervix ready to open in response to contractions. If you don't do the ripening stage and your cervix is not already prepared, you triple the risk of needing a Caesar. So basically,
Wow.
the ripening stage or the preparation stage of the cervix is to
Yep.
try to reduce your risk of Caesar. And so if your cervix is not already ready for induction or for labor, then there are three options. The first option is Prostin gel. So this is a gel with a prostaglandin in it, so a hormone in it. So this is inserted into the vagina. It's quite easy to insert, like it's just an examination, so not particularly painful to insert. It needs to be inserted regularly, so sometimes every 6 to 12 hours, depending on your response to it. The major drawbacks with the gel, and the reason why I don't use it, I've only used it once in my whole career, actually. The reason I don't use it is because once you put it in, you can't remove it. So if your body responds sensitively to it, and you get lots of strong contractions, I guess, too early, it can stress the baby out, and even before you're in labor,
Yeah.
and you can't remove it, you can't stop it.
Okay. Yeah.
The other issue with the gel is that it can cause a significant response. Like it works well in preparing your cervix for labor, but sometimes it works too well. And that can stress the baby out too before you're in labor, and then you end up with a Caesar. So that's the major issue with the gel. The time I've used the gel is in a woman who has not succeeded with the other two options, which I'm just about to talk about. And then for her, the gel did work. So it is an option, and I think it's a reasonable option to use, and a lot of obstetricians will use it, but it's not the only option. The second option is pessary, the brand name is called Cervidil. It's the same hormone as the gel. It has a hormone in it. The difference is that it's in a ribbon, like a little ribbon, like a tampon almost, but it's thinner, that you put into the vagina, and it stays in overnight for 12 to 24 hours. That releases a hormone which softens and gets the cervix ready for labor. So this option is good because it's not too uncomfortable to insert as well. It can cause contractions similar to the gel. The difference is you can remove it. And I find that sometimes it works really well, and sometimes it doesn't work at all. So I find that it's not that consistent in its effect. The third option is a balloon. There are different types of balloons that can be used, but essentially they work on the same premise, which is there's no hormone in the balloon. So I think it's a bit more natural in that sense. And it sits not inside your cervix. So a lot of women think that the balloon inflates inside the cervix and mechanically opens the cervix. It actually doesn't. It sits on top of the cervix, so in your uterus. It sits on top of your cervix and puts pressure on the top of the cervix. And that pressure simulates a fetal head. So basically is trying to do what the baby's head should be doing to stimulate the hormone production, the prostaglandin release from your own cervix. So your own prostaglandins to soften and open up your cervix.
Right.
And that will stay in for 12 to 24 hours as well. And then the following day you break the water. So my preference is the balloon. The main drawback of the balloon, there's nothing perfect, right? The main drawback of the balloon is there's about a 1.5% risk of flipping the baby to breech.
Oh.
So because it inflates in the uterus between the cervix and the baby's head, it can push the head up a little bit. And if the baby does a kick at the wrong time, it can turn the baby around, which is annoying. But that's probably the main drawback. The other drawback with the balloon is they can be a bit more uncomfortable to put in. So putting them in.
I was just about to ask, how do you get it in?
Yeah, so it's similar to having so another thing is that everyone, when I say balloon, everyone's thinking about party balloons. I mean, they're thinking about this big head size, basketball size balloon sitting in their uterus. No, it's not.
Oh,
so the balloon is about, I'd probably liken it closer to a water balloon.
Okay.
So they inflate to about 3 centimeters in diameter. To insert the balloon is similar to having a pap smear. So we use a speculum. We look at the cervix and we thread, it's a little catheter, like a little tube. The diameter of the tube is about half a centimeter, maybe even less, probably about 3 to 4 millimeters. So maybe like thinner than a crayon. And that would be threaded through the cervix, and then the balloon is inflated once that's threaded into the cervix. The balloon is inflated in the uterus.
Yeah. Okay.
Yeah.
And if your baby does flip breech, do you then just remove the balloon and hope that the baby flips back again? Or
if you're being induced, there's a reason we're being induced. So we probably wouldn't be waiting a long time after that. So you take the balloon out. You can, if the baby's breech, you'd then manage it as you would if the baby were breech even without the balloon. So you'd have 3 choices really. The first is to try a vaginal breech birth. There's a whole nother talk, Kath.
Okay, right. We'll schedule it in.
Yeah, but the first is to try vaginal breech birth. The second is to, which I wouldn't necessarily recommend. There are only certain circumstances I might even suggest that as an option. Second option, which is probably a good option in this circumstance, would be something called an ECV, which is to turn the baby, external cephalic version, which is to turn the baby through your abdomen. So basically, it's kind of fancy, kind of cool, actually. We can make the baby do a somersault inside your tummy. That's the second option. And the third option is to do a Caesar.
Okay.
Yeah.
I do want to get you back for when because
Very,
I just did an episode. I just recorded it. It hasn't been published yet, but well, at the time of recording now, but about birth positioning and optimal baby
Yes.
positioning with the
Yeah.
midwife. And
Yeah.
I know there's different opinions with midwives versus doctors
Yeah.
on
About
that
positioning.
whole,
Yeah.
positioning and if there's actually anything we can do to help support it. But anyway, as we mentioned, that's a whole other
Yeah, no,
topic.
we should talk about that because I've got things to say about it, and it may not be what you expect either.
Yeah, right.
But yeah, no, good. Yep, yep.
Okay. Let's move on. I've really just because I'm aware of your time and I know you had a mum in labor, is that right?
No, today I've got my son with me.
Your
He's
son.
sick. He's away from
Okay.
school, and so I've had to have him at home, or not at home, at work with me actually.
Yeah.
I was teaching the medical students this morning,
Yeah.
and then I'm taking my daughter to her singing class tonight. So I've got
Oh,
everything
that's
balanced.
nice.
Delivered the
And
baby
he's,
yesterday. Have two planned for the weekend.
yeah.
So it's a bit, so it's busy.
Yeah. And your son's just hanging out in your office.
Just hanging out in the office.
Yeah, I
Yeah,
love it.
yeah,
Okay, I'm looking at my list of questions. We've scooted through all the pain relief options.
yeah.
Um, the final question.
You can
Oh,
ask a couple if you
no,
like.
no, wait, you did. We talked about the methods of induction, yeah. And you talked about the three methods.
Yeah. Oh, I didn't talk
Do
about
you-
the actual induction, did I?
yes,
I didn't quite
exactly.
get
So
there.
let's
Yeah,
just
no,
let's
thank you.
just
Thanks,
finish
Kat.
that off before
Yes.
I.
So once your cervix is prepared with
Yep.
one of those three options, sometimes you have to stack them. Like if you use the pessary, for example, and it doesn't work, you then might try the balloon. So you might have to do that. Then th- we then we put a drip in your hand, like a little cannula. We do an examine. We take the pessary or the balloon out if you've got them. If it's the gel, we just leave it because can't remove it. We do an internal examination with our fingers to break the waters. So usually
Straight
that's just
away, or do you
uh,
wait?
yeah. So if it's the pessary, we'd wait after removing the pessary at
Hmm.
least half an hour to break the waters. Um, And then, we can break the waters, but we just wait until we start the drip. So we break the
Yep.
waters, and then after we break the waters, we start a hormone drip, oxytocin. In Australia, the brand name is Syntocinon. And we run that at a titrated rate. So we can control how quickly or slowly we increase it or decrease it. So this is another thing with induction that a lot of women get worried about. They blame the drip when the baby gets stressed. And I can understand this because what happens is they're getting contractions, the baby's getting stressed, the emergency button gets pressed, everyone runs in the room. The first thing that happens is they turn the drip off or down, the contractions go away, the baby is not stressed anymore.
Hmm.
Then they say, okay, we need to get you back into labor, get your labor going again. We'll start the drip again. We start the drip again. The baby gets stressed. They turn it down. The baby's not stressed anymore. So everyone thinks it's the drip that's causing the baby to be stressed, the oxytocin that's stressing the baby out. It's not the oxytocin, it's the contractions that the oxytocin is causing that is causing the baby to be stressed. So again, association and causation.
Mm.
So here it's the lead down effect of the drip that's causing the contractions, and the contractions are causing the stress. The difference is we can turn them down and we can turn them off. If you're in spontaneous labor, can't do it. So if the baby's stressed with your spontaneous contractions, we can give you some medication to try to slow them down, and that does help a little bit, but only temporarily. And so we don't have as much control in that setting for stressed babies. But I hear this a lot. I had my Caesar because my baby was stressed because I had the drip. But it's not the drip, it's the contractions the drip are causing.
Hmm.
Mm.
Okay, so you're playing this game where you're the drip up and down,
Yep.
what are your options?
If you're turning the drip up and down, the problem there is you got a couple of competing stakeholders. The first is the mum, second is the baby. This is the same
Mm,
in all of obstetrics. There's always two. Um, so if you're turning the drip up and you're getting more contractions, you need that. You need contractions to dilate for your cervix to open. It's not just dilation. We always talk about dilation as the main thing, but it's other things too. How low the head is coming with the contractions, what position the baby's head is in, how thin the cervix is. So all of these, the more contractions or the more regular and strong your contractions are, the better the head will progress through the birth canal. Um, and if we're turning the drip down, it either means that you're getting too many contractions, like more than you need, or more likely, the baby's getting stressed with the contractions. So if it gets to the point where you have to turn the drip up to give you contractions, but as soon as you get the contractions you need, the baby's too
mm,
stressed to keep going, then you're unless you progress by luck or maybe the contractions that you are having are enough to make you progress, so that can happen. Um, Unless that happens, then you end up having a Caesar.
yeah, okay.
I should also say, like, we talk about Caesar like it's a horrible thing. It's not the
Mm.
worst thing in the world. Like, there's
Oh,
much, much worse
absolutely.
things. And as an obstetrician, I'm sad to say I've seen the much, much worse things.
Yeah,
It's not horrible at all.
no,
Like, Caesars are okay.
yeah,
It's hard when that's not what we want.
yeah.
And if you don't want a Caesar and you have a Caesar, it can sometimes feel like it's that like that you've done something wrong or someone's done something wrong
Mm,
or it's just not right. But the most important thing is that you're safe and that your baby's safe. And
yeah,
and I think it's important that you only have a Caesar if you want one or if you really need one.
yeah,
Um, but but at the same time, like if you need it, you need it.
yeah. I'm so glad you said that, Shavi.
Yeah.
Caesars aren't the devil at all.
They're not the devil at all. Like we talk about it like they are.
Yeah.
Like, but and I think part of what happens then is women get tricked into thinking that their birth type, either normal birth,
Mm,
Caesar, no epidural, epidural, forceps, vacuum, women get tricked into thinking that they have had a
yeah.
substandard
Experience.
or
Mm.
yeah, like
You
something that
failed or
failed,
yeah,
that they failed.
yeah,
And then and so we think we're helping women, we're empowering women, we're promoting women by telling them that you should make sure you have a vaginal birth.
yeah,
It's not true. Like
yeah,
we're not helping them. We're
yeah.
making it harder for them. We we
Absolutely.
we just got to keep it safe,
Yeah.
and do the right thing
For both mum and baby.
for both mum and baby.
Absolutely. I'm so glad you said that. Right, I've got one more question, and
Yes.
I think I know the answer, but and it's a very vague question, but I kind of like it. Because let's say someone's thinking, okay, or someone's been told they might need an induction in a week or whatever. Is there anything, I know the answer. I shouldn't
We
answer,
should
ask
ask
this.
or
But I think it's I know that
ask
this
me.
is something that a lot of people do think. Is there anything women can do to prepare for an induction, or is there anything they should do differently to prepare for an induction?
So one good thing about induction is actually, well, good and bad, I think. And some women don't like induction for this reason, actually, is that you can time it. Like you know when you're
Mm,
going to go into labor. Um, so that's good and bad. Some women don't like that idea because then they don't sleep the whole night before because they're
mm,
expecting it to happen the next morning. They'd much rather be woken at 2 in the morning and just go. But some women really like it, especially when they've got other children
yep,
to try to factor in. Um, there isn't really much to do to prepare for an induction. It's the same thing I'd say to prepare for labor.
yep,
So
mm,
whatever you would do to prepare for labor, do the same thing for induction.
yep,
Um, induction is just we start your labor off. We can control your labor. That's about the only difference between induction and labor, spontaneous labor.
yep.
Um, yeah.
Okay, great.
Uh,
Any final words for anyone listening today who perhaps was feeling a bit unsure about an induction or a bit
I,
hesitant?
I think it's reasonable to be unsure about induction. I think that's okay. Like whenever something is happening to you, especially if you're not really sure, of what it is or understand it very well, it's important to ask questions. So I will always encourage my patients to ask me questions, because in my opinion, if you know more about what's going on, if you know what I know about what's going on, it's much safer. It takes the load off me. It makes it easier for me, actually, if you know more about your labor, but at the same time, it's much better for you. So it's important to know, I think, why you are or aren't being induced. Like sometimes you might want an induction and your doctor might say no. So maybe ask them why. Usually, if that's the case, it's because you're asking too early. But ask them why. Like, it's important to know why what's happening. And then after the birth, really importantly also, and I think this happens a lot more in the public system because it's much more time pressured and there's higher volume, but ask about what happened as well. So after the birth, if you have a Caesar or a forceps or even a normal birth without a tear, just ask what happened. Like, how did it all go? Because even though you're in the mix of it, you don't necessarily know what's going on.
I love the fact that you said that.
Yeah. So
it's a debrief.
It's a debrief.
Ask for a debrief.
Because and this is something I do routinely, and I tell my registrar, my training specialist the same thing, is that, like, for us, if we do a forceps or a Caesar, for us, we do, I don't know how many a week, maybe 6 or 7 a week, right? A vaginal birth or a Caesar or forceps or whatever. And so for us, it's just every day. But for you, for the woman, you might only see 1, maybe 2, and that will be yours, and that's it the whole time. So what we think is normal, while it is normal and medically normal, you won't necessarily know that it's normal. So it's important for us to tell you that was normal. Like, that was great. You did great. Like, yes, you had a forceps, but it was fantastic, and the baby's come out perfect, and you've got just a little tear, and it's gonna be okay. And just us telling you that will change your perspective of your birth and your labor, and will have an impact on how you recover, but also how you approach your next labor. And I think that's really important too.
Fantastic. Lovely way to finish. Thank you so much, Shavi. If someone wants to connect or connect, what's the best way that people can find you?
I'm on Instagram at Dr Shavi, at DrShavi. I've also got a Facebook page, and you can message me directly there. I get scammers on there as well, so just make sure you mention Kat's podcast as well, so that I know where you're coming from and that you're not some nutter. But just make sure, because I may or may not reply otherwise, but I'm always very happy to answer questions. That's my style. I find that I operate better. So I'm glad that this was you asking me questions thing, Kath, rather than I was going to tell you what's going on. Because I prefer answering questions, because I think it's also a very efficient way of getting you the knowledge that you need. But yeah, you can connect with me there. That's easy.
Amazing. Thank you. And I'll put all the links in the show notes. Thank you so much for your time today, Shavi. I really appreciate it.
My pleasure, Catherine. Thanks for having me.
It was great to chat. Thanks for listening to the Pregnancy, Birth and Recovery podcast, brought to you by Fitness Mama, your app for home-based, physio-led pregnancy and postnatal workouts. If you found this episode helpful, please tap follow, leave a quick review and share it to your stories. Tag at kathbequee.physio. I'd love to connect and cheer you on. And don't forget to check out the free trial at fitnessmama.com/free to start feeling confident, strong and supported today. Until next time, remember, a strong body, a confident birth and empowered recovery is something you deserve. This podcast is for informational purposes only and is not a substitute for individual medical advice, diagnosis or treatment. Please consult your healthcare provider for your personalised guidance.